to everyone watching today. Appreciate you joining us this morning for our third Zoom call featuring one of our own medical advisory board members to share some amazing research underway for Koolen-de syndrome. Also, hello to all of you, as we mentioned on Facebook. I know many of you are watching there, and then those of you who have logged into the webinar, we just really appreciate you being here. My name is Kaci Fisher, and I'm going to be your host today on behalf of the Koolen-de Syndrome Foundation. I am mom to Hudson, who is 9 and was diagnosed with Koolen-de syndrome at the age of 6. I, like many of you, have had the experiences and challenges of seizures, and I'm really, really excited to talk to Dr. Myers today. I know this was a talk that many of us were really looking forward to just hearing from him. So I know we have a lot we're going to learn over this next hour. So speaking of Dr. Myers, this is who we are going to share the Zoom screen today. And just want to give him a hello and welcome before I introduce him. Dr. Myers, thank you for joining us.
Well, thanks very much for having me, Kaci.
We're really glad you're here. Dr. Myers is a pediatric neurologist and epileptologist at the Montreal Children's Hospital in Montreal, Quebec. He was born in Kingston, Ontario, and completed the majority of his medical training in Calgary, Alberta. Before going to Montreal, he completed an epilepsy fellowship in Melbourne, Australia, involving multiple research projects related to epilepsy genetics, including a study of spectrum epilepsy phenotypes seen in Koolen-de syndrome. His other research interests include genetic epilepsy phenotyping and incorporating clinical trial protocols into epilepsy precision and medicine research. And I can tell you, I actually read his entire CV. It was like 30 pages, and it was incredibly impressive. So I know you've done a lot of great work, and we're excited to learn more about that today. I would be remiss if I didn't mention that we're also meeting today in thanks to the Koolen-de Syndrome Foundation, and this foundation's commitment to educating, increasing awareness, and promoting research for the support and enrichment of individuals living with KdVS and their families. If you want to learn more about the foundation, we encourage you to visit kdvsfoundation.org. A bit of housekeeping before we get started. You all submitted so many great questions, and we are going to do our absolute best to just get through as many of those today as we possibly can. But if we can't, we'll do our best to continue to have these types of calls so we can answer those questions. We're hoping if we have a couple of minutes at the end, we might be able to take additional questions. So if you are live on Facebook, unfortunately, we won't be able to get to those, but we can try and get to some here in the webinar. You will see a Q&A button at the bottom of your screen, and we've got Ashley watching for those questions to come in. And again, if time permits, we'll try to get to those. And then also wanted to let you know that the call is being recorded, so we will share a link afterwards. And of course, you'll be able to go back and watch it on Facebook anytime you so choose. So I wanted to give you, as we always do at the start of this call, just a very brief history of the syndrome. We know that many of you that are tuning in may be very early in your journey and may not know a lot about our syndrome here. So we wanted to just give you this brief history for context. Koolen-de syndrome was first identified in 2006 and named after Dr. David Koolen and Dr. Bert de Vries. It's a genetic syndrome involving the 17th chromosome, and it's caused by a microdeletion or a mutation of the CANZL1 gene. This mutation causes, or deletion or mutation causes developmental delays, learning difficulties, and can cause a number of other health concerns. And as I mentioned earlier, many of our Koolen-de families do experience seizures. And so talking to Dr. Myers today is truly a privilege. So speaking of research, let's get to know Dr. Myers. We're going to start with just a few general questions because I think it's always a joy for families just to get to know you a little bit better. So can you tell us a little bit about what drew you to the field of pediatric neurology?
Sure, yes. So, yeah, I guess in medical school, there were a lot of things I was interested in, but pediatric neurology is really kind of unique in that it's really interesting academically, like the conditions that people have are really fascinating. But also, I guess I figured out that I just like working with children a little bit more than I like adults too, but that it's, I mean, people say it's a privilege to work with children. I really think that that's not just a cliche, it really is true. I feel really lucky every day to get to do what I do, and particularly with the Koolen-de aspect, I've really felt lucky for to be able to attend the gatherings I've attended, and also just the communications I have with families. Yeah, I guess that's sort of how I got here.
Yeah, and that was actually one of my questions. You just mentioned about attending the gatherings. What is that like when you go to these patient advocacy summits, especially someone who's researching this particular syndrome, just to meet those families and have that personal contact with them and their children?
Yeah, for me, it's really just sort of amazing and energizing. Research sometimes can be a little tough. There's a lot of sort of rejection when you're submitting papers to journals, and sometimes it doesn't seem like you're working really hard and not getting anywhere. But yeah, going to the gatherings and seeing just how excited everybody is that sort of research is happening in their area, and seeing that it is helping people. Yeah, just every time I've come back, I've just been on a high for weeks. So yeah, I'm really happy that you guys have invited me, and hoping to go to more in the future.
Yeah, we are too. It's always interesting, I think, when, especially for those families that are a little bit newer and maybe haven't had the opportunity to interact with you all as much. I can personally remember we kind of felt like you all were rock stars a little bit. You hear a lot about the research, but to actually get to meet you all in person and hear straight from you about it, I think is really, really encouraged to the families and these Koolen-de Vries individuals. So we're always really appreciative of you all. Can you tell us a couple of fun facts about yourself that are completely unrelated to research and science?
Sure. Yeah, I guess outside of work, distance running's the thing I really like. I used to be kind of a kind of runner, and I still really, it's a part of my life, just getting out, and especially on trails, things like that. And the other more recent thing is I guess a cliche in the pandemic, but I got a dog for the first time in my life, just a few months ago, and she's roaming around. And yeah, I don't know, it's been just a big, really fun experience for me.
Excellent. Okay, and then how did you first become interested in studying Koolen-de Vries syndrome? And then what do you find most interesting about the study of it?
So when I finished my residency, I was going to go down to Australia to do my fellowship with a couple of researchers there, Ingrid Scheffer and Sam Berkovic, who are very well known in the sort of epilepsy field. And I think what happened was, just before I was going to go, Ingrid was at a meeting talking to Bert de Vries, and Bert was saying, oh, this is the syndrome that I'm involved in, and half the patients have seizures. And we said, well, what kind of seizures do they have? How do they do? And he said, oh, he's an amazing guy, obviously. He's a geneticist. He said, oh, I don't know so much about that, but somebody should really study it. So Ingrid said, well, by coming down, who's already in North America, so that's how I ended up going to the gathering in Asheville in 2015. Because yeah, I'll admit, I think most doctors, I hadn't heard of the syndrome before that. And obviously I read a bit before I went down, and then got to meet all the families, and yeah, I've just sort of been excited.
That's amazing. It's always really interesting to hear as we talk to each of you that are part of the medical advisory board, kind of how you got involved. And I think those stories are always really interesting to the families. So what I think would be really valuable today, before we get into the questions from the families, because there are so many, but you have a PowerPoint presentation you put together that I think is really helpful for families to better understand, the research that you're currently doing. And so if we could just kind of briefly walk through that, and then I think that will really lay some great groundwork before we get into the family questions.
Yeah, sure. So as you said, I'll try to go through this a bit quickly, just because I know there's a lot of questions. I can always come back to aspects of it if anybody wants me to. So yeah, I'll just start off with just a brief explanation of what a seizure is, because a lot of people don't really know much about this. So basically, there's a lot of different kinds of seizures. So in a very general sense, a seizure is basically something where you have abnormal activity building up in the brain that causes some sort of a change in the person experiencing that. And this might be stiffening of their body, just sort of blank staring. They could vomit, may have jerking of parts of their body. They could sweat. They can go pale or blue. They can have more kind of complex behaviors. They can have abnormal eye movements. They can get some feeling, and then sometimes they can just sort of suddenly fall to the ground without warning. And this is not even all of the things that can happen. So in terms of the types of seizures, that, like I say, there's a lot of different types, but we can sort of generally separate them into generalized seizures, where both hemispheres become involved at the same time, or focal seizures, where the seizure seems to start in one part of the brain. And when we say that somebody has epilepsy, it's a very general term, and all it means is that they've had more than one unprovoked seizure. By provoked, I mean we wouldn't count a seizure if they hit in the head right after that, or they had an infection of their brain, or some other provoked reason for a seizure. One little exception to this is that there are certain EEG patterns where we might diagnose you with epilepsy after just one seizure. And if there's also some reason where you have a really high likelihood to have more seizures after having the first one, you can also get a diagnosis of epilepsy that way. So in Koolen-de Vries syndrome, as I said, one of the early questions was, the early studies had shown that maybe around half of patients had seizures, but there was really not much known about what types of seizures they had. Do they just have one seizure and never have another one? Do they have 20 seizures a day and they're really hard to control? Medications that worked or didn't work? And are there any sort of typical findings on imaging of their brain? So this is actually, it's an easy thing to study if you have a common disease, but it's a very difficult thing to study if you have something that's relatively quite rare, like Koolen-de Vries syndrome. Most neurologists are going to maybe see one patient in 15 years. And certainly if you get together a good number of them is very challenging. One second. We're taking my, but fortunately, with gatherings like Koolen-de Vries families have organized, there's an opportunity to get stories from a reasonably large number of patients. And so when I was invited to North Carolina for this Cool Kids gathering, basically the goal was to try to get the clinical data on as many Koolen-de Vries patients who'd had seizures as possible. So I remember this very well. I was there and was still a trainee at the time, and you see Drs. Koolen and de Vries there, and I definitely felt like they were definitely the rock stars there, and going around, I think they went to Dollywood and a bunch of outings. And I mostly actually set up shop in the lobby and just sort of anybody who had a free minute to sit down and talk with me. I went through the history of their seizures. And so out of this, we were able to get 31 patients who'd had seizures. 26 of these came from the gathering in North Carolina. And in terms of, and this was actually really important in terms of getting sort of representative sample because we got almost half of the people that attended there. And when you think that half of people with Koolen-de about are supposed to have seizures, this meant that we thought our study was going to give a pretty representative idea of the spectrum. We weren't going to get the most severe people because they're the ones interested in participating, or we weren't going to have any other kind of bias like that. Yeah, you see their ages range from 2 to 35. Most of them had deletions, but we did have a few with one. In terms of what we learned about seizures in KdVS, seizure onset is most commonly in childhood, but there is a fairly wide range. I've seen it happen up to late in adolescence. The most common seizure is a focal seizure, so that's the seizure that starts in one part of the brain. The type of seizure we'd classify them as would be focal seizures with impaired awareness. So that means that the patients are not able to respond normally and maybe completely kind of unaware of what's going on around them. And one aspect that came through quite frequently was what we call autonomic symptoms. I won't go into much detail about what the autonomic nervous system is, but we would see things like sweating or vomiting or going pale in quite a lot of these seizures. Another aspect that seemed to be a little unique was something called status epilepticus. So, a little background: seizures almost always stop within a minute or two. And it's really, really rare for a seizure to go more than 5 minutes. When it does go more than 30 minutes or more than 5 minutes where a medication has to be given to stop it, we call that status epilepticus. It's fairly uncommon, and it is something that can be life-threatening. And one sort of an unfortunate aspect of KdVS is that the incidence of status epilepticus is much higher than you would expect in people with epilepsy overall. About 2/3 of that experience.
Oh.
Another aspect that I think particularly important for a lot of KdVS parents is that there was a subset that have a very specific EEG pattern that, depending on where you are, will be called continuous spike wave in sleep or epilepticus in sleep. These are usually abbreviated to ESIS or CWS. And these are important because we sometimes see these in patients who may have only had a couple seizures, but this pattern is often associated with developmental regression. The patients are losing developmental skills. And get this pattern to go away, usually with medication, usually their development will pick up again. So for patients that have had developmental regression, I will usually end up recommending an EEG that captures sleep. You need to see the activity in sleep to know whether or not a patient has this.
Dr. Myers, can I stop you for 1 second? Because there was actually a question exactly about that from a family member that was asking, if they do, maybe their child has never had a seizure before, but they are seeing some of that regression. So would you recommend in that situation to go ahead and try to get an order for an EEG just to check that activity?
Yes. So as a neurologist, not just for KdVS, but any time a patient has had developmental regression like that, I would definitely get an EEG and one capturing sleep. So that there's different ways to do that. Sometimes we'll do ways to keep their child up late the night before the EEG. So when they come in, they're tired and they fall asleep during it. Not just kids, some people won't sleep in the clinic. So in those cases, what what I would do next is something called a home ambulatory EEG, and that's where sort of come in, we put the electrodes on the head, all wrapped up, and you get a little backpack, and then they kind of go home, sleep at home next morning, and get off and record. Depending on where you are, that may not always be an option. I guess the third option is to actually be admitted to hospital and have EEG monitoring with where you're on video and closely monitored in hospital. That's a lot more expensive healthcare system, but sometimes that is necessary.
And would there be any reason, one more follow-up question to that before you move on, would there be any reason, so we talked about regression, and then certainly if you're suspecting seizure activity, but with these Koolen-de individuals, would there be any other reason they'd want to get an EEG? Because that was another thing parents asked is, you know, they know this is pretty common, but maybe their kid hasn't had one yet. Is there anything else they need to do kind of prophylactically to determine any activity?
There haven't been any events concerning for seizures. There hasn't been any sort of real developmental regression. I probably wouldn't do the EEG because it's in general not a great idea to order tests if you don't know what you're going to do if you get the result. And so if a child had not had anything that was really very convincing for being a seizure, the EEG absolutely could be abnormal, but I wouldn't start treatment for them unless I actually thought they had seizures or if they had this. But it sometimes just ends up adding more anxiety.
Sure, that makes sense. Okay, thank you.
So yeah, just to wrap up, I'll just go kind of some things we saw on the MRIs. So we tried to actually get the images on disc, and we had our pediatric neuroradiologist review them. And there was some, definitely the MRIs are very different between patients, but there are some common patterns we saw coming back fairly frequently. So one is abnormalities of the corpus callosum. So down at the bottom here, this is an MRI of a normal individual. And what I'm indicating here is something called the corpus callosum. Basically just a structure that connects the right and left hemispheres. And this is sort of what it should normally look like. And in the patients with KdVS, we saw kind of a variety of different abnormalities of the corpus callosum, but often it seemed to have only sort of incompletely formed, and often sort of the sort of back part of it either not formed at all or it seemed sort of short. That seems to be a pattern often seen on MRI. Again, down at the bottom here, we have a normal brain, and we're looking at it kind of face on. These structures here are called the hippocampus. They're involved in memory, but also are very common for seizures to start. And we saw that these structures seemed not formed properly in a lot of patients. The yellow arrows point to that here. And the last thing I'll mention is something called periventricular nodular heterotopia. So now we're kind of looking down on the brain from the top. In a normal brain, the outer part is called the cortex, and it's made of what we call gray matter. And then the rest of it here is called white matter. And when the brain develops normally, the cells in the cortex multiply here, and then they move out to the cortex and kind of organize. Sometimes that migration doesn't happen properly, and you end up with little nodules of gray matter that should be out here, didn't make it out there. And we saw that in a number of patients as just another kind of brain malformation. So, and then these were just sort of one-off. I'm not going to discuss those, just so we can. In terms of the course of the epilepsy, a lot of patients were very difficult, had seizures that were very difficult to control initially. But the good news is that a lot of those patients eventually had their seizures resolved and were actually sometimes able to come off medication completely and not have their seizures come back. I guess the take home there is that if you're going through a tough time right now, I can't promise you it's going to get better, but there's a good chance that it could. In terms of which medications to use, overall, patients seem to do a little bit better with a group called benzodiazepines. Clobazam is an example of that. Or sodium channel blockers. Carbamazepine is an example of that. I won't use the brand name to avoid bias. Overall, it seemed like patients did relatively poorly with levetiracetam. The brand name of this is Keppra. But I'll just say it's not wrong to be on Keppra. If Keppra is working for you, that's fine. If I was seeing a patient with KdVS, it wouldn't be my first choice, but it absolutely could work for me. So, so there was a question, I think, about refusing to take it. My suggestion there would be to maybe show the paper that I have a link to at the end, and I think it's getting put up somewhere, to your doctor. And you know, there's some evidence that the Keppra is maybe not the best. They have some reason that they really want to use it. There's certainly a chance that it works very well for your child. And the last thing, so when patients have epilepsy that's very difficult to control, and particularly when they have focal seizures, in general, we sometimes look at whether or not to figure out where the seizures are coming from and remove that part of the brain to try to cure their epilepsy. In people with KdVS, I would generally say that's probably not a great idea because brain malformations are probably in both sides of their brain, and from coming from one place, they might start coming from another. However, there was one case that we came across where a patient on MRI had what's actually a low-grade tumor. I don't want to scare people. This was not something that we would have expected to become really aggressive. But it was something that that was resected, and the patient actually, I was told, did quite well after that. I would also get an MRI in everybody with KdVS who's so I think I probably summarized things fairly well, so I'm going to skip this. And I'll just close with a couple notes on kind of what we have going on right now, and what has been done since then. We did think that maybe cancel-1 mutations could cause other types of epilepsy, so we screened a cohort of patients to see if they had any variants, but they didn't answer. So it seems like cancel-1 really is mostly responsible for KdVS alone. From the MRI data that we had, it really seems like the way the brain develops is not a normal organization in KdVS, but it's hard just with normal MRI to figure that out. There's some more advanced techniques that you can use to see exactly the pathways and the connections between different parts of the brain. An example of that called tractography that you do with something called diffusion imaging. So with Angela Morgan, that some of you may know, she's a speech pathologist in Melbourne. We've been working on trying to get diffusion imaging done in a group of patients with KdVS. So far, we had sort of just gotten started, and then the pandemic hit, and unfortunately that sort of a lot of things. We are trying to get it back going now, but I mentioned thesis CSWS. After the initial paper, there were sort of more patients who contacted us about this. So I'm getting a paper together describing those patients, basically with the goal of trying to understand if there's treatments that work better for them, how they tend to do overall. So I've got 7 patients so far. One thing that's sort of linked to epilepsy, I think it's at least neurology, is that in the past, I don't know, a few months, a couple of families have emailed me saying that they sort of knew about the seizures and the seizures maybe having autonomic features, but they were saying that they had children that were having just kind of a lot of different symptoms that were kind of autonomic. But in some cases, they'd actually had an EEG on, and they were definitely not seizures. But it still seemed like their autonomic nervous system was maybe not really working properly, and what we call dysautonomia. So far, it's only been 2. But if anybody out there has had sort of a similar experience, please feel free to email me. It doesn't seem to really be that well described, but it is probably an important thing to try to understand to help people. Yeah. So yeah, I think that's all I really had for that. So we can move on to questions, I guess.
Yes, and 2 things, Dr. Myers. We'll be sure after this call, that's something we can post to some of our groups too, about those particular individuals that are having that. Maybe we can just see if there are more people that can reach out to you, and we can point them your direction. Also, and we'll post it to our Facebook page and our foundation page. Also, Dr. Myers, people are saying they're hearing most of what you're saying, but it is starting to cut out a little bit. So I just don't know if there's any, I don't know if we can fix it right now, but if there's any little tricks you have that might be helpful while I'm pulling up the questions.
Yeah, let me. Yeah, I'm going to dial in on my phone.
Okay, great.
Welcome to Zoom. Enter your meeting ID followed by pound. Enter your participant ID followed by pound. You have entered the meeting as a panelist. Attendees can now hear you speak. This meeting is being recorded.
Okay, is that better now?
I think it is. Yes, I think it is. It just started right during your talk, kind of going, we got what you were saying, but it was going in and out just a little bit, and there's so much important information. I wanted to make sure everyone can hear you. So I'm going to jump into these parent questions because we have quite a lot of really, really good ones. So one of the questions we got a few times was, can you just tell people just the best way to handle a seizure? So we've got, you know, that family that's their first one, and or maybe it's their 10th, but what would you recommend is just kind of that basic seizure protocol?
Sure. So yeah, I mean, seeing your child have a seizure is probably one of the more terrifying, traumatic things anybody can experience. So everybody has a very tough time with that. The most important thing really is just to try to keep them safe. Some people will have heard that you can't touch somebody having a seizure or things like that. You can absolutely touch them. And so if they're like in water or near something hot or they could hurt themselves, you can just move them away from that. If you can get them in, depending on the type of seizure, if you can get them kind of into a recovery position where they're kind of lying on their side, that's preferable, but that may be difficult to do. And you know, again, there's sort of some older stories about like putting like a wooden spoon in their mouth or something like that. Don't try to put anything in their mouth, particularly don't put your fingers in their mouth because you might lose them. and as I say, most, like, you know, more than 95% of seizures will stop on their own. So, so just sort of make sure they're safe, and then once the seizure ends, you know, they're going to be confused and tired. So you can just sort of talk to them as they're kind of coming back, but they may take a long time to come back. Some extras, if you can remember, timing how long it lasts is always helpful. And I know there's a question about videoing them. Videos are really helpful for us because they can help us sort of figure out what kind of seizure it was, and that can help us understand what's going on, and also there are certain medications that work better for certain kinds of seizures.
And is there a rule of thumb? I know you talked a lot about the 5 to 30 minutes. So, I mean, if you get to the point that it's been 5 minutes, are you kind of safe to assume you probably need emergency help, or maybe they're not going to be able to stop on their own? At what point would you recommend calling 911 or something?
Yeah, definitely at 5 minutes. And I mean, if it's the first seizure, most people are going to call right away. It's totally appropriate. There are unfortunately some patients who've had sort of recurrent status epilepticus. So for those, unfortunately, their parents do kind of get used to it a little bit. And there are rescue medications that they can have with them that they can administer to their child. Some of them are given rectally. There's other things that you can dissolve in the inside of the cheek or squirt into the nose. So in those cases, sometimes they don't have to call an ambulance every time. Yeah.
Okay. Yeah, and another question that was asked by a parent kind of while we're talking about this is, of course, you know, I think for a lot of families, these seizures are happening during the night, which we talked about earlier. So is there anything that you would recommend that a child could, or an individual could wear that would help alert to the seizure, or any suggestions there just so parents can be made aware?
Sure. Yeah. So there are a lot of devices out there now, and I'll just say up front, I don't have any relationships with any of the companies that make them. I think there's one called Embrace that has. I've been told by some families that they were very happy with it. It's I believe it's sort of a monitor that's worn on the wrist, and so it sort of senses movement. There are also some things that are under, like, sort of sensors that would go under the mattress, things like that. One thing about pretty much all of these, though, is that they can detect kind of convulsive seizures. So if it's like a tonic-clonic seizure, sort of where you go stiff and then shake. But if it's a seizure where somebody is just sort of like that focal impaired awareness seizure where they're just sort of becoming not aware, maybe they have some vomiting or things like that, those are much more difficult for devices to pick up. Sorry. Yeah.
No, I think that's really helpful. And you know what, you talked about this a little bit earlier, but just how you are seeing where some individuals do stop having them as they get older. Have you seen where that's typically adolescence or adulthood, or is there any magic number there?
So it's really variable. It's usually by adolescence, I would say, or during adolescence.
Okay.
But I did talk with some families who'd had like only 1 or 2 episodes. I think in one family it was actually status epilepticus, and then didn't have any more seizures at all. And that was in sort of fairly early childhood. So there really is a big range, but the more common time to kind of grow out of your epilepsy is in adolescence, but it could happen at any time.
Okay, and then what about the reverse? So if a family has never experienced that with their Koolen-de individual, is there a time that you would typically see onset to be more common? So, you know, let's say that they're 8 years old and they haven't had one yet. Is there still that possibility you feel like they may have one as they get older, or any kind of things to watch out for?
So I guess there's always a possibility, but I would say if they've made it to adolescence, like if they've made it to 13 or so without having one, the risk has become quite low. There was one patient who I think she had her first seizure at like 17, but I only remember hearing one story like that. It usually is sort of before adolescence that it starts, if it's going to start.
And is there anything you can do? We got this question quite a bit, just preventatively, diet, supplements, anything you know of that could potentially help prevent seizure activity?
There's nothing really we know of right now that could prevent, epilepsy starting. In general, more for people that have already had seizures, like the things that provoke them are like sleep deprivation, like or stress. So, trying to have a good regular sleep pattern is just good for everybody. So I guess that's about all I'd say, but it's more just sort of good common sense taking care of your child.
Sure. Okay. And then also, let's see, have you seen any correlation between seizures and ADHD in Koolen-de individuals?
It's not something we've really studied yet. In general, not just in KdVS, but just in general, ADHD is a little higher in patients with epilepsy. It's, I guess, also important to know there's some medications that could probably exacerbate that a little bit. Again, levetiracetam or Keppra can sometimes cause people to become a little irritable or have different kind of psychiatric changes. Clobazam can actually do the same thing. It could probably happen with any medication, but it's possible with all those. Topiramate is another one where sometimes people just are a little bit slower in their thinking, so they might have a bit more trouble sort of with school performance. So.
Gotcha. Okay. And then also, how does epilepsy affect the brain long term? So that's another question we've gotten a lot too.
Yeah, so that's a really good question. So we do know it's definitely not good to have seizures that are more than 30 minutes long. That particularly if it's a sort of a tonic-clonic convulsive seizure that lasts that long, that probably has some degree of permanent damage on the brain. In terms of the shorter seizures, I get asked this a lot just in general because some parents don't really want to start a medication if they sort of say, well, what's so bad about having some short seizures? We basically think it's harder for people to learn if they're having a lot of seizures and if they have even just the sort of abnormal activity going on in their brain. So these are, I guess, yes, one of these things where the short answer is we don't really know, but it probably is not good, particularly in a developing brain.
Makes sense. And then what would you recommend? You've answered a lot of them actually about the drug-related questions, but we got a lot of those, as I'm sure you can imagine. What do you recommend when just nothing seems to be working? And is there something else that could be going on that's causing that? So someone asked me, is it possible it's related to metabolic problems, or could there be something else that's causing the body to just kind of reject those medications?
So, yeah, I guess the metabolic question, there are some people that break down medication very, very quickly. So I guess if you want to be sure that they were able to get a sort of reasonable level in their system, some of the medications you can check the level of the medication in your blood. As far as, so I guess maybe that gets a bit of why they might not work. If they don't work, like if you've tried a number of medications and it hasn't been successful, the next steps would usually look at things like the ketogenic diet. There's something called a vagus nerve stimulator that's it's sort of like a pacemaker in your chest, and then there's a little wire that goes onto a nerve in the neck, and that can at least reduce seizures in some people where medications have really not worked. Yeah, that's sort of, I guess, where I'd say we go when medications are not working.
Okay, that's really helpful, because actually that was going to be my next question about the ketogenic diet, as we've had a couple of people mention that was something that had been helpful. So I just wasn't sure if you could elaborate on any additional experiences you've had with that. It sounds like maybe something worth trying.
Yeah, I mean, anybody who's having seizures that aren't that are difficult to control with medications, ketogenic is worth considering. It is a lot of work for the family, and it's unfortunately in a lot of popular culture right now of people talking about sort of going keto, but it's not a healthy thing, and there are, just like medications, there are risks that come along with it for vitamin and mineral deficiencies. So when we start the ketogenic diet, at least at my hospital, we started in the hospital. Patients get admitted for it. And then they're followed very closely by a dietitian. So I would really recommend families not sort of try to just do it on their own, because it is a potentially dangerous thing.
Okay, that's very helpful. And then one more drug question. So we got a lot. With the advent of medication screening based on individual biology, is there any work going on to find seizure medications that way?
Not that I'm aware of in KdVS. Yeah, I guess maybe the short answer is not that I'm aware of, but as I think probably the person who asked knows, there's in general a lot of people trying to study precision medicine in different conditions, including epilepsy.
Okay, let's see. So the other question we got several questions about Corpus Callosum, so we might need you to explain that to everyone watching. And then, is this common in other cool individuals? Is there anything you can kind of speak to as it relates to that particular condition?
Sure. So maybe I'll just share my screen again to put.
That'd be great, because everyone's wanting your email address again too. So while you've got your screen up, after this, maybe you can share your email address.
Sure. So well, I'll come back to that, I promise. So yeah, so this is, again, at the bottom, this is a normal brain. Can everybody see my arrow? Okay.
Yeah.
So this structure here is the corpus callosum, and it connects the two sides of the brain. And in this study, that was all patients with epilepsy, we found this sort of partial agenesis of the corpus callosum in a number of patients. I don't remember the exact percentage. Now, this is not actually really something that we would think of as something that really increases your risk for seizures. When we, outside of KdVS, when we come across people that have either completely absent corpus callosum or partially absent, they're sometimes pretty close to normal. They often will have a little bit more trouble with doing activities where they have to sort of coordinate both their hands together. But they can sometimes do quite well. At, I think the meeting in Utah, we actually discussed trying to look at the MRIs of people that hadn't had seizures to see how many of them had corpus callosum problems as well. Unfortunately, it's been a little hard getting those studies together, so we haven't. So I can't really answer that question right now. But it would not surprise me to see this in people that had not had seizures.
Okay, and is there any link between that and hypotonia? That was another question we got too.
So in general, I'll just go to this so people can get it. In general, we sometimes see hypotonia in people that have agenesis of the corpus callosum, but it's not clear that that's the reason they have hypotonia, and they may have other genetic reasons, or other parts of their brains are not formed properly to explain that.
Got it. Okay. We've got just a few more questions. We got a question about, can the working memory be improved for these kids that find learning very challenging?
So, the main way to, I'll take down my email, but we can email it out if anybody needs it. The main way to do that is with sort of with therapists in the school. I'm not really aware of any sort of medications or things like that would be able to improve that.
Okay, and regarding just intellectual disability in general, just anything you found that might be helpful for families to know regarding Koolen-de syndrome? I know we've talked a lot about seizures, but just anything else neurologically you would want to speak to?
So it's been a little while since I've gone through the data on that. My impression is there's also can be a fairly wide spectrum of intellect. Maybe just because I haven't gone through it recently, I'll leave that one.
Okay, and then another question we got was if you had the opportunity to review data that's submitted on GenIDA. I know a lot of our families contribute information there, so just wondering if that's something you get access to or if that's helpful.
I haven't reviewed the raw data. I know there is a paper, hopefully it's going to be submitted soon, that I reviewed the paper, and I'm a co-author on it. So I've seen the sort of summary data, but yeah, I don't have access to go in to review every file.
And then another just general question, and then I know we have just a few minutes left. So Ashley, if you want to be looking to see if there's any in our queue. But one more thing is just kind of in generally speaking. So as you think about just all the families that are currently watching today that are prepping for visits with their pediatric neurologist, and maybe it's their first visit, maybe it's not, but what would be just some advice that you would give them on things that they should have prepared and ready to go, and just questions that they can ask? I know you said the paper, which I think getting that in the hands of families probably is very valuable, but what else would you say?
Another, I think, I guess as one would tell you that pediatric neurologists do work hard, but we see a lot of different rare things. So it's sometimes hard to, or impossible to be an expert in every rare syndrome. So I think but I'm always happy if people bring me a paper or two about their syndrome or tell me what they've learned, because not just for KdVS, but there's lots of conditions where there are, Facebook groups where people are hearing about different advances. Yeah, I guess if your child had seizures, I would suggest bringing maybe our paper, the one on seizures. There's something called, there's a website that's free to access called Gene Reviews. And if you just Google Gene Reviews and Cancel1, like KANSL1, it provides a really nice summary sort of for clinicians. And it was written by, Doctors Koolen-de and Angela Morgan, who's also a doctor. And that could be a good resource for clinicians. And I think that's all you should really have to do. I mean, your doctor should do the work for you. Some of the questions back.
Yeah, no, that's really, really helpful. Ashley, I know we got 4 minutes left, but I saw some really interesting questions as I was trying to look at them really quick coming in through the chat. Do you want to open up your line and ask a couple of those?
Sure. One question that came in was, I know we talked about the Embrace and Empatica kind of device that you wear around your wrist. What about detecting heart rate changes? Would that help? Were there any monitors or anything that would come in handy to detect seizures in that way?
So I think some of them do that now. I'm afraid I don't know the details of them. And I guess with anything like that, you'd want to be careful. You'd want to have something that's not going to give you a whole lot of false positives, because our heart rate can change for different reasons, and you just sort of generally want to find something that's going to hopefully reduce your anxiety a little bit, rather than going off 5 times a night. And so yeah, sorry, I don't know too much about how they're integrating heart rate into the newer devices.
All right, thank you for that. Another question that came up was related to ADHD. Any medication recommendations to treat ADHD?
Sorry, I'll be right back.
Okay.
We have so many good questions coming in, Ashley.
I know, it's great.
Sorry, go ahead.
That's okay. Related to ADHD, any medication recommendations to treat ADHD that would not reduce the patient's threshold for seizure?
I mean, I realize it's on the packaging often that ADHD medications can reduce seizure threshold. I have lots of patients on them, and I honestly can't really think of a time where I saw a patient's seizures clearly go up with the medications. So I would say more just to go with whatever your doctor thinks is the best medication for your child's symptoms.
Okay, thank you. Another question that came up was, do you feel like every KdVS child who has seizures should see a neurologist, or would a pediatrician be able to handle the seizures?
No, I don't think they would need to see a neurologist. There are, childhood epilepsy is quite common, and there are some very typical syndromes that a lot of pediatricians will be very comfortable with. So if you have a pediatrician who's reasonably comfortable with epilepsy, and the seizures are well controlled, I think you don't need to necessarily move on to a neurologist. If the seizures are not, well controlled with the first 1 or 2 medications, then I think most pediatricians would prefer to a neurologist at that point.
Well, thank you, Dr. Myers. We have several more questions I don't think we're going to be able to get to today, but everyone is greatly appreciating your time today.
Yeah, and there's one I saw come in, and one I want to ask you really quick, because it came in early before the webinar, and I somehow just failed to see it. Can you speak real quickly to, is there any connection between seizures and psychosis? That was also asked in our pre-webinar questions. So hearing voices during seizure and that kind of thing. Yeah, that's a really good question. So during a seizure, you could have hallucinations as part of the seizure. It's also possible to have something called post-ictal psychosis, where you sort of have a seizure and then afterwards have a period of psychosis, which can be different things like delusions or hallucinations or other things. And it's also important to know that some medications can bring this out, and levetiracetam is actually the most common one for that as a side effect. So if you had seizures and then had been treated with that and then started to have psychosis, I would
definitely let your doctor know, and maybe another medication would be better.
That's very helpful. Thank you. So we are about to wrap, and I want to end on a positive note. And I saw, because this has all been amazing, but some of the stuff with seizures, Dr. Myers, as you know, it's hard. It's hard to talk about and sometimes can be really hard to process. But one of the things that came in, and I thought was a great question before we close, is just a lot of these individuals, though, have amazing memories. Their ability to recall information is really, I think, quite exceptional. Anything you can speak to there that might speak to why so many of these individuals have that ability? Because it's kind of fascinating.
It's a really good question, and I'm really happy to hear that. I don't. The short answer is I don't know, but it does seem like the brains are organized differently. And while that maybe can lead to some problems like seizures in some people, and sometimes intellectual disability, maybe it makes certain aspects in some people work better than the average person. So the brains are different, but not necessarily worse, or if that makes sense.
It does. Yeah, it does. That's really neat. Well, thank you again for sharing today. I think this has just been amazing information, and we knew that this would be a super popular call. So we are just so grateful that you have taken the time out of your schedule to join us. So again, huge thank you to you. We want to thank all of you that have tuned in live via Facebook and on the webinar. I know we went a few minutes over, but I just feel like the information was just so valuable. And we hope that you have really gained a lot of great insight into this conversation today. We plan to have more events coming up, which is very, very exciting. And we also have a committee that's currently planning for a virtual summit. And then, of course, we'll have hopefully our in-person summit again in 2022 once we get through this pandemic a little further. If you'd like to learn more about Koolen-de syndrome, the research, and how you can get involved with the foundation, please visit kdvsfoundation.org. And we will look forward to connecting with all of you again soon. Thank you again for joining us. Dr. Myers, thank you. We really appreciate your time today.
Thank you very much.
Bye.
Bye.